So let's begin. Welcome again. I think I've seen most of you in the HIV in my country session. This session, the testing guidelines and implementation of the guidelines and service delivery model, is one of 3 sessions that we're going to go ahead and provide. The second one will be the community-based testing, and the third one, the self-testing and self-sampling. So let's call it a trilogy. Today, we will go through with Maka and Daniel, first of all, the testing guidelines and implementation from WHO and ECDC to give you an overview of what the guidelines are regarding testing in general. Then Maka will take over to talk about, actually Daniel, I think it's going to take over after me, to talk about the overall testing options that exists in Europe, including the key populations. And then Maka will follow for a presentation and a discussion on the role of NGOs and the quality of services around testing. So I'll start with my the first part of the first session. I'm Christos Krasidis. I am calling from Nicosia, Cyprus, and together we will go through the basic guidelines. I'm for those of you who don't know me, I am a member of EATG and a trainer in the EATG Step Up Academy since 2018. So this is the second time for me that I'm a trainer here. And at the same time, I'm an activist, a human rights activist. I'm a community health worker at the Cyprus Checkpoint, which is the Center for Prevention, Information and Testing of the AIDS Solidarity Movement in Cyprus. And I'm also a member of the Steering Committee of AIDS Action Europe. And I'm focusing through that role on the COPA test network, which is a network of CBVCT checkpoint centers around Europe. So I would like us to have a discussion while we are doing this presentation. So the format is that we're going to go ahead with the presentation, then a short discussion, then Daniel will take over with a short discussion, and then Maka in the same format with a longer discussion then to put everything together. So where does it all start? It all starts from the UNAIDS Target, which is known as 1990-90. So what is the 1990-90 target of the UNAIDS, which has been adopted, and we are all trying to go ahead with this target to basically end HIV. The philosophy is this. The first 90 is from all the people who are living with HIV in the world. The target is that we can reach the 90% of them to know their status. This is the first 90, the knowledge of someone living with HIV that they are living with HIV. The second 90 is the 90% of the first one. So it means out of the 90% of people who know their status, out of these people, 90% should have access to treatment, access to antiretroviral treatment. And this is the second 90 that is completely dependent on the first one. This means that if we are not reaching 90% of all the people who are living with HIV so that they know their status, and we are reaching, for example, 50%, that means reaching the second 90 is completely dependent on the first one, and that means there are still going to be out there people who don't know that they're living with HIV. So it's important. This first 90 is very important. So the second 90 is out of the people who know their status to have access to treatment, and then the third 90 is out of the people the 90% of the people who have access to treatment to be able to reach an undetectable viral load, which means that they will not be able to, apart from, of course, monitoring the HIV infection, they will not be able to transmit it. Now, as a community, we've added, and we are, I will use the word demand, and we are demanding a fourth 90, which is not included in the 390s of the UNAIDS target, which is out of all these people who know their status, they have access to treatment, and they have monitored and through the treatment, they have reached an undetectable viral load. The idea is to have these people have a quality of life. So it's not about just knowing your status and then having access to treatment and then reaching an undetectable viral load, but it's also being able to lead a quality, a life of a quality standard. Now this 90-90-90 was created obviously to end stigma, because if we manage to reach that third 90 that is dependent on the second 90, that is dependent on the first 90, then we are expecting that we will end HIV infections. The only problem is that what is happening with the 10% of people who are left behind. So, this 10%, if we're not reaching this 10%, and if we're not demanding for 100% of the people who live with HIV to know their status, and then all of them to have access to treatment, and then out of these people, all of them reaching an undetectable viral load, you do realize that who are we leaving behind, and what does that mean? To reach the first 90, the major and the possibly only way to reach it is testing. So for 2019, I would like to say that this target was initially set for 2020. We didn't reach it, obviously. So it's moved to 2030, to 2030. So right now, the numbers that we have from 2019 is that the first 90 is 79% of people know their status, know that they're living with HIV. And out of them, 62% have access to treatment. And out of these people who have access to treatment, 53% have an undetectable viral load. And the fourth 90 is kind of missing. So I don't want to go through very technical stuff. I just want to give you the basic idea of what testing is and why this is important, and we can discuss that in the last session, in the last part of our discussion. So let's first define what testing is. So we need to understand when we're using the term testing, what do we mean? WHO has a definition for testing, and it's not just testing itself. It's a full range of services that should be provided together with HIV testing. And when we're talking about services, we're basically talking about counseling. So we're talking about a brief pre-test information, then the test, and then a post-test counseling. And if we have a reactive test, then we're talking about linkage to care, linkage to care and treatment services, to do a second and a third test to make sure, to confirm that the person is really living with HIV, because the tests we're using are not 100% accurate when it comes to an HIV reaction, especially the first line test that we are using, that are antibodies and antigens, are definitely not 100%, but they are quite good. They have a sensitivity of above 99% when it comes to a reactive test. So whenever we are talking about a testing service and the term testing, just bear in mind that we're talking about a full range of services that also include counseling, pre-test and post-test counseling, and linkage to care. Now, just to go ahead with the guidelines, more or less WHO and ECDC have the same guidelines. WHO is the World Health Organization. I've put some main bullet points that I'm going to highlight some of them at the end of this presentation, but it's mainly about implementing a strategy on testing across different countries. It's about, the second bullet point is about using self-testing as well for the people who are not attending or using testing services, whether these are implemented by the public health or community. So the second point is HIV self-testing, to have access to it. The third bullet point has to do with the network-based HIV testing. So it means that having key populations, having access to testing, and allowing people within communities to bring other people to get tested. And we're talking about men who have sex with men, people who inject drugs, sex workers, transgender people, people in prisons, and their partners, all of the previous groups' partners. Let me just say that when we're targeting on specific population, I always like to use the phrase that we are targeting, but we are not we should not be excluding anybody. So targeting has to do with resources and how many tests we have or how much funding we have and where we should be targeting, but that does not mean that we have to exclude people from getting tested. Now, there is an issue with having a reactive test. How long does it take to confirm that the reactive test is actually positive? So that means that you need to have a second and a third test, and that usually, especially with Western blotting methods, it has been taking 4 to 6 weeks. So the new recommendation is to use rapid testing, rapid diagnostic tests that minimize this waiting time to confirm a test down to 1 to 2 weeks. And it also allows us, community health workers, but also the states, to lower down the affordability, the cost of testing. And the WHO recommends that we do HIV and syphilis dual testing. So we're talking about tests that with the same test, you can actually have a result for HIV reaction to HIV antibodies and reaction to syphilis antibodies together. This recommendation has to do with also eliminating vertical transmission, not only mother to child, but also trans father to child, for example, and include not only HIV testing and syphilis, but also hepatitis B testing. Let me say that for hepatitis C, we now have a cure. So we have a treatment that cures hep C. WHO is basically focusing on HIV and hep B, and of course other STIs, starting with syphilis, but not only. Now I've got links on all of the slides, so when you have the slides, you can access the sources. When it comes to CDC has 6 principles, more or less, is covering what we've already said from the guidelines and recommendations of WHO. So the it's a bit more analytical though, and I tend to like it a bit more. So we're talking about the first principle is that testing should be accessible, voluntary, and confidential. And of course, with consent. The second principle is to have the appropriate information available for these people after the testing. So we're talking about the post-testing, the post-test counseling, or the information you're giving after the test. The third is the linkage to care if you have a reactive test, to effective treatment and care. The fourth principle is about normalizing testing everywhere. That means that we should not be promoting testing only in case that someone is going under an operation or is worried, for example, because of their sexual practices, but make it a routine testing, normalize HIV testing, just like any other testing that people are having as a routine. The fifth principle is about testing for HIV, Hep B, and Hep C, and the health workers having the training to do the testing. And the sixth principle is about the implementing a strategy on an organization level, but also on a country level that can address testing that can reach the first 90 out of the target of the 90. Just to make things a bit, there are two more slides on ECDC. First of all, ECDC is talking about where to test, and it's giving recommendations of where the testing can take place in primary health cares, in hospitals, in other settings, pharmacies, prisons, harm reduction services, community testing also, and promoting self-sampling and self-testing. Now, apart from where to test, who to test, it's more or less the same guidelines that WHO is recommending. So you can see the bullet points. I don't need to mention anything more, but it's a bit more analytical, but more or less we're talking about the same populations and the same groups and the same communities. And I will try to present a practical, in terms of a visual, something that maybe you can remember. When we have an HIV testing, first of all, the person who is doing the testing, according to these guidelines, they should have access to information and training. And specifically for HIV testing, when we have the first, the pre-test counseling, it can be short and quick, giving information about HIV, then implementing the HIV test, and then if the test is negative, then the idea is to provide combination prevention. Combination prevention includes condoms, gloves, lubes, access to PrEP, the pre-exposure prophylaxis, and PEP, post-exposure prophylaxis, and access to programs for exchanging needles where needed. Now, and of course, retesting. And there is a cycle there. So someone who gets tested and has a negative test has access to combination prevention, and then goes back into testing again and using the combination prevention depending on their individual needs. Now, when it has to do with when we have a reactive test, there needs to be a support to the person who is being announced a reactive test in order to link them to care do the after we have the second and the third test. So we know that the initial reactive test is confirmed. Then the access, the linkage to care is about linking people to treatment and monitoring, and not only medical but also psychological care, and then reaching the U equals U, which is the result of the treatment as prevention. So this is the cycle, let's say, of the guidelines, which I try to put them together into a slide, so you can have a visual image of it. Now, when we're talking about HBV, hepatitis B, then again, there is a pre-test counseling and information about HBV, and then we go ahead with the test, and we have a non-reactive and negative test. Again, access to combination prevention when it comes to sexual practices, and needle exchange programs for those who need it, and then retesting. Now, if we have a reactive test for HPV, again, there needs to be support, linkage to care, and reaching the treatment for HPV and continuous monitoring. Now, when we're talking about HCV, so hepatitis C, there is a treatment now. So testing is really important, but it all leads to, if you have a reactive test, to actually having the access to the treatment for hepatitis C. And the same thing goes for syphilis. If there is a reactive test, there is a treatment. So again, having access to that treatment. I will finish these guidelines with an announcement that actually took place yesterday on the 26th. It was a common press release by ECDC and WHO calling for improved HIV testing in Europe. Now, you can access these press releases together with the HIV surveillance report for 2020 that was released yesterday. I will only highlight out of this whole text that in 2019, 1 in 5 new HIV diagnoses was in a person over 50. So we're talking about late diagnosis. This is the one thing that we need to highlight. So when we're talking about testing and reaching the first 90 of the 90-90-90-90 goal, a target, we should not really leave anyone behind, and maybe worry a bit about that 10%, and we can have a discussion on what that means later on, because apparently there are people who are aging with HIV and they don't know it, and they haven't, maybe there is no culture of doing accessing routine testing, or maybe there is stigma around testing. Stigma is not only about living with HIV, but also about testing. Those of us who are living in countries who are smaller or have a lot of stigma around sexual practices and gender identities and sexual orientations, you know what I'm talking about being afraid to get tested. And the other 3 points that I want to highlight closing this presentation is the 3 points that ECDC and WHO are calling for improving HIV testing in Europe. The first one is prioritizing. So we're talking about raising awareness about testing. If you go ahead and read the publications and the report, you see that there are specific recommendations that basically are saying that peer awareness and networking-based HIV testing, having people within the community, bringing other people in the community, or using peers to disseminate the information about testing seems to be through evidence-based research more successful rather than promotion on TV or on radio. Obviously, promotion of safer sex in various ways and combination prevention, which includes condoms, loops, gloves, needle exchange programs, and substitution therapy and PrEP. Now, the second point is about providing efficient HIV counseling and testing, which also has a reference to rapid diagnostic services and to community-based testing and self-testing. Let me just make a short comment on this point, that there is a new guideline that is pushing by WHO, that is pushing the use of rapid testing instead of Western blotting. So we don't have delays in results of testing. The third part is, the third recommendation is having rapid access to quality treatment. That means if someone has a reactive test and has a confirmation test and is living with HIV, has to have access to treatment quickly. Now, this is it from me as a first introduction of the guidelines of WHO and ECDC, and I will keep the presentation open so I can maybe share the screen, so I can show you in case you have any questions or any of the slides or anything else. So before we move on, questions? Hi, Greg.
Hi, Christos. I only want to refer to the data that you have shown after 1990, the real data, the status data. Maybe I missed it, but what is the geography of this data? Is this the worldwide data or European or?
For the 1990, I think you're talking about this slide, right?
Yes, exactly. Correct.
Okay, this is the world data.
Okay.
This is the world data that is reported through WHO on where we are on the 390s for the international level.
Do you think that this is reliable data in terms of 79% people really know that they are?
That's a very good question. I think that if we see data on different groups, for example, like I was seeing the results of the 1990 on the aging on the populations that are 50 years old and above, the numbers are completely different. If we see the numbers in Africa, they are completely different. If we see the numbers in Eastern Europe, they're different. And I can just give you my point of view coming from Cyprus. If you see the data in Cyprus, we don't have any. I mean, we do have data, but we haven't managed to calculate the whole 1990 result yet.
Okay.
So this announcement, at least through WHO, I think it's about the data that they already have, which is mentioned as the data from 2019. I can look into it and see. I hope I haven't made any mistake on preparing this data, but really the 1990 result on the data is completely different depending on where you see, from which angle and to which population or country.
Okay, thank you.
Do you mind if I add one thing to that?
Please, yes.
So broadly speaking, all data on all international reports is only as reliable as the information sources provided to calculate that data. So when you see the 90-90-90 globally, you have to look at it knowing that so first of all, much of the data is based on estimations. There's no 100% accurate calculation to how many people live with HIV in the world. So everything is an estimation. So there's always a margin of error. Christos showed the simplified version. In the full reports, usually they show an interval. And if you look at both ranges of the intervals, it's a big difference in terms of the absolute number of people. And obviously, as Christos was saying, the epidemic is very different from place to place. And in some parts of the world, the data that is reported has a lot of limitations. In the EU EEA, the surveillance system has improved in some parts of Eastern Europe as well over the last decade. But there's still a lot of data limitations in a lot of countries, EU, EEA included, Eastern Europe included, etc. So it's semi-reliable. It's reliable for some countries, not as reliable for others. And it's best, this is to give you an overall idea. If you're interested in a specific country, it's best to check up the regional reports because they have the data sources. So you can check exactly how good the data is, so to say.
Okay, thanks.
And if I can add to that, when it comes to the 90-90-90, if you go further on to the second 90 and the third 90, at least I'm aware that in Cyprus, the tool that is being used is the ECDC tool to calculate that, and it needs a whole lot of data of viral load, counts for people living with HIV in the country at different, when they were first diagnosed and at specific intervals. So if you realize that this data, until at least in my country, which is a small country, and we should have had better data exactly because it's a small country, it was in analog formats, in files and were not even digitalized. You can imagine how accurate this data is. So I think that there is a long way ahead us to reach the 90-90-90, let alone the 100-100-100. And I would like to address the part of who is that 10% we're leaving behind. I think we can address that in the end, in the overall bigger discussion we can have at the end of all three sessions. Is there any other question? Any other questions regarding this first presentation? My effort was to basically simplify things, to put them into 20 minutes so that people can understand the general idea, whether you guys are going to be doing testings yourselves or not. Obviously, this is not enough for that. It's just to give you the base.
Hi, Christoph. Sorry, I would like to add something because we are working here with the Fast Track Cities strategy with the UNAIDS, and I think, I am not 100% sure, but I think that as the target wasn't reached for 2020, they changed it to 2030, and it's going to be 95, 95, 95, and 0 for stigma. So that change. That's true, right?
The target for 2030 is still the same. It's 95, 95,
It's
95, 0 stigma by 2030. It's still the same target from the start. What happens is, there's no formal report yet, but from the progress reports that we've seen so far, we won't get to 90, 90, 90. So it's failed. We knew it pretty much from the start. It wouldn't be possible. But it's a long-term goal. So the idea is how much have we progressed towards that goal? And there were a lot of countries doing a lot of very good things. There were others not so good. But in fact, the targets are the same. It's 95, 95, 95. There are also targets for other infections. And in practice, what's going to happen is that UNAIDS is coming up with intermediate global framework, which will come out early next year, with targets for 2025. So it's kind of an intermediate step. This was foreseeable already from the global monitoring. It's very hard to do a strategy for 15 years or 14 years. So 1999 was published, I believe, in 2015 or 2016 with a target to 2030. And so it would be normal that there would be an intermediate framework. I've seen the first draft of what they're doing. It seems very interesting, actually. They'll probably publish it around March or April next year, I believe. And so we'll have a framework until 2025, but it's always towards the 95, 95, 95 and zero stigma.
Anyone else before we go ahead?
Christo, hello.
Manuel.
I want to ask to you about other questions. Are you talking about the self-testing of HIV because it's recommended in the guidelines? Now here in Adara we are a program we offering for a free shipping service for rapid tests by our own website. But I think I feel a little problem with the self-test because we are offering a lot of stuff. Now we are celebrating the European Testing Week, and because that we have a lot of demand of this self-testing, 300 people are demand this test, but we don't have the information. It's difficult to have the information in case of the positive result, because when you are offering in live here the test, you can get the information immediately. But when you are offering the self-test at home for the people, it's more difficult to offer the linkage for in case of the positive result. What's your opinion about that?
Manuel, that's very true. That's why we have the third session. This one is for, let's say, a general approach to testing. And then we will go into the second session that is community testing, and the third session that has the self-testing as well, and the self-sampling. So you're completely right on the concerns of linkage to care, but I think we can leave it for the third session that we're going to discuss exactly that.
Sorry, I wait for that.
So if there is no one else, we will have some time to discuss at the end. So I think we can move on to Daniel. Daniel, you're next, right?
So let me start by, since we're speaking about testing, I was going to share two links. Christos, I'll share the first, which is the new surveillance report on HIV that ECDC just published. And I just linked in chat the link for a rapid communication that we just published as well on the impact of COVID on testing for HIV, hepatitis, and sexually transmitted infections. Very briefly, as an introduction, let me just say that you're going to have to put up with me for a few sessions. So there are things that I will only touch very slightly here, and then we can discuss further ahead in other sessions. Today, the idea, as Chris has already mentioned, is to give you a general overview around testing. And my specific objective was to give you an overview about service delivery models, so options for testing, and the system of testing itself. So to give you a very quick background, I'm not going to read all of this. If you have interest, you can check the slides after. I've been working for 10 years in HIV, mostly in prevention testing and linkage to care. And over the last mostly 5 to 6 years, I've been involved with a series of multilateral initiatives, as well as European and global agencies in a lot of stuff. This is a small a short summary of a few of them. I think that if you don't know these structures, organizations, etc., the links are there to give you an idea of what's already happening around Europe. So let's start and go quickly. Just to say that if you have any questions during the presentation, feel free to flag or to raise hand or write in chat or something. I'll try to keep an eye out for questions. If there's something that's not clear, just unmute and say I didn't get that or something similar, and I'll do my best to explain. So we're talking about testing. So testing is not a standard thing. There are a lot of ways of testing people for a lot of different infections. You have a million types of different tests for different diseases. So here we're going to look at mostly HIV testing, but also hepatitis, sexually transmitted infections, and TB as, let's say, a pack. And I'll explain why this pack is important further ahead. You probably already know it. I'll just refresh. So when you got a test, let me give you a note. I'm not sure how used you are to participating in virtual trainings, like participating as in speaking. I'm going to ask questions that can be rhetoric or that you can respond to. If you feel comfortable unmuting and responding quickly, please feel free. So my first question, and this one I would really like a response, is what's the most critical element of a testing system? What's the most essential thing of a testing system or of a health system in general? And someone will have to say something, otherwise I will not continue.
A protocol, maybe?
Protocol is important, but it's not the core element. More options. Okay, so let's do one thing. In the interest of time, I'll keep going. Feel free to jump in at any time. So the most important element of a testing system or any system is the person. And you can't test if you don't have someone to test. So unlike what happens normally, we should look at testing systems from the point of view of people. So you have a person that needs a test, or that you want to test. You have a series of options to provide that test to the person. If we're speaking about HIV, there are mostly 4 levels of service delivery. So 4 levels at which you can deliver these services, which are community organizations, primary care, hospitals or clinics, and laboratories. Now, all of these are under some sort of programmatic management. So there's another level to the system that we have to think about when we're looking at it, generally speaking, which is the level of management. Management includes financing, logistics, procurement, a lot of different things. But also, and influencing all of these service providers, we have monitoring and surveillance, we have laws and regulations, which vary from country to country, and we have the whole overall policy and social environment. So as a testing system is something complex. It has a lot of things that factor into it. Then they go from society itself to laws to the infrastructure, how many labs you have, what equipment do they have, what tests can they do. All of this has an influence. So generally speaking, testing or diagnosis systems, they can't be one response. One response will never do in any testing system. So the idea is you give people choices that are comfortable for the people to get tested, because you want them to get tested. Otherwise, you have a lot of sick people, and you don't want that because it's expensive, speaking from a policy point of view. It is especially important to ensure that those who have a bigger probability of being infected have most access. And in practice, this is usually what does not happen. Usually the most wealthy and the ones who live closest to the response structures, the service delivery providers, are the ones who have more access. The ones who are most informed are the ones who have more access. And these are not the ones who need it the most, for the most part. Which means that there's also a series of structural determinants, which includes stigma and discrimination, that we have to think about. However, if you're thinking of the system as a whole, there's a series of boxes, let's say. There's a series of basic interventions that need to exist with good monitoring. And the monitoring part we'll speak about in another session, which are testing for indicator conditions, which is something very specific that you can check up on the guidelines, which are, basically speaking, it's if you have one infection that is usually associated with another one. A practical example is mononucleosis in HIV, for example. Weird mononucleosis cases are usually an indicator condition for HIV. So if you come up to a health service with that, you should be offered an HIV test. Testing of pregnant women is also a basic in any testing system. PICT, which is provider-initiated counseling and testing on places where there's a high prevalence of an infection, is also recommended. Community led or participated voluntary counseling and testing is also essential. Self-testing and self-sampling, especially in the context of COVID, is also very important, and the linkage to care issues are very, very important. Partner notification and contact tracing are also a key part of the system. And out of all of this, you have to think about responses for the people who don't fit in any of these, because there will always be people who don't fit in your boxes. So these systems, as we've seen, are pretty complex. Let's say that we have a TB testing system, which has all of this in it. Now, usually systems for testing, for treatment, whatever, they're developed vertically. That means that you develop a system to respond to one disease. And usually what you end up having is this. You have three closed systems, which sometimes speak between themselves. But usually speaking between different disease systems doesn't really exist in most places. And so there's huge inefficiency here, especially for these infections, as well as STIs here. Because if you look at the guidelines and the epidemiology, the people who are most at risk for one of these usually are most at risk for others. And we'll look into that in more detail just ahead. Apart from the complexity of the system itself, it's hard for the person. I mean, if I want to get an HIV test, let's say I go to a community-based organization, so I have to go there and they'll give me the result. In principle, they'll give me the result in the same place. But if I have to do a confirmatory, so if the test is positive, I have to go from either primary care or community, I have to go to a clinic to get a confirmatory, and they have to take my sample, send it to a lab. The lab has to analyze it, send it back to the clinic. And then I have to go back to the clinic myself. And from the clinic, I get the results. And then I get another consultation. And then this cycle is endlessly repeated after I have a reactive test. And if I start treatment, I'll continue to do this. Now, imagine if I want to do this, or if I want to get tested, and if I need treatment for all three infections in vertical systems. It's chaos. And for people who have little money, low literacy, often have difficulties with language, or who are marginalized or discriminated, the more contacts you need with the system, the more probability you have of losing these people. And this is one of the reasons why integration is important. So usually integration is thought of as adding more diseases to the response. So integration of testing is usually I test for more things. But actually, integration can be looked at from different levels of the testing response. So from a policy and program level, as we were speaking, like the fact that systems do not communicate between themselves means there's huge inefficiencies and a lot of wasted money. And integrating management between disease programs can bring to massive gains. At a site base, you can obviously test for multiple diseases, but you can also integrate other services. And Christos already spoke about this, not only prevention, but also links to other essential services such as social support, housing, food, employment, harm reduction, mental health, etc. So in the real world, with our example here from Portugal, we have over 20 or it's close to 30 testing sites, all collecting data to a centralized database. So we've been doing this for a few years, and we have quite a few thousand people. So what you see here on the left side is the number. So we test for HIV, hepatitis B, hepatitis C, and syphilis. And what you see in the left side is the number of reactive tests for each of the infections and how many of these people are co-infected. I'm not sure if you're familiar with these diagrams, but you read it in the, can you see the pointer, the cursor here? Is it visible to you?
Yeah,
Yes,
we
okay.
can.
Wonderful, thank you. So this is all reactive tests for HIV. Okay, these here are HIV and hepatitis C reactive. This one here is HIV, hepatitis C, and hepatitis B. Here it's all four. Fortunately, no one had all four, and etc., etc. So what you see from this is that if we were only offering HIV testing, we would have missed 2019 people with a reactive test that we had in our services. And so we would have lost 2019 opportunities to connect people to healthcare. And so it's a waste and it's a bad service to people. Obviously, we don't offer 4 tests to the 4 people. They can get them if they want, but we have a triage to know which tests are suited for the person in order also to save us money and time. Now, to the right, you see key populations reach. This is self-reported, so probably there are others who are not reported here. And this does not include checkpoint data, which would add a lot to the MSM numbers here. You see that we have a lot of migrants, but you also see that regardless of what key population we're looking at, there are overlaps. So there are people are not a box. If we have a service for migrants, there won't be just migrants. There will be MSM migrants. There will be MSM migrants who use drugs. There will be MSM migrants who are sex workers and use drugs and are MSM. And our services need to be prepared to deal, regardless if it's testing or anything else. We need to have an environment that is suitable for all of these people. And this doesn't always happen. In harm reduction centers, for example, discrimination towards LGBTI community is quite frequent, actually. And if it's something that if it is not worked, if it is not discussed, it can cause issues in access for people who are LGBTI. And it's roughly the same if you turn it around. I mean, chemsex, for example, people who inject drugs in a sexual context in the MSM community face a different type of discrimination, but there's also they're also seen in a very particular way. So services both for MSM and people who inject drugs need to be prepared to deal with specificities. Well, all services need to be deal with specificities because people are complex. And you see here the distribution amongst specific groups. So as expected, I mean, people who use drugs, you see mostly hepatitis C, still quite a bit of HIV and syphilis, but migrants, you see a ton of hepatitis B, for example, and a lot of HIV, unfortunately, as well as syphilis. Going for an MSM specific example, you see that community testing can have a huge, huge impact on the overall number of new cases diagnosed in countries. You see an example here. You can look at it in the link below. You can see the presentation in detail and look at the numbers if you're interested. But just to highlight that, for example, in Greece, 37 out of 100 MSM in the country are diagnosed in these 2 community testing sites. In all of Spain, 9 out of 100 MSM are diagnosed in 2 community testing sites. It's 80 million people in Spain, 80 something, I believe. Italy, 4 out of 100. It was I think the second year of Bologna checkpoint, and Lisbon, 23 out of 100, also 1 testing site. So you see that we can have impact, a lot of impact. Now, a bit more technical, and I'm close to wrapping up. Each of these actors, of these service providers, can have different roles. And the way that you structure your system and the equipment that you have available, as well as the technicians that you have available, the training that people have, make a big difference. This is an example from tuberculosis with the different types of assays that you can do in different types of laboratories. So even within laboratories, you can't do everything everywhere. What this means is that we have our integrated testing system. We have a person. The person wants to get tested. She has these 4 levels of service provision. Usually, the bulk is done here for all infections. For HIV, HCV, and TB, still in many countries, the majority of tests are done in hospitals and clinics and through laboratories. So those are the critical components, the ones who produce more volume. Then you also have community organizations who have been gaining a lot of importance. Remember always that there are different levels in the laboratories, etc. And the thing is, over the last few years, we've been having more and more options. So 10 years ago, half of the options that we have today to test people did not exist or were not really developed. And we have, for example, point-of-care molecular testing, which can be done at all levels of the system and can give us diagnosis instead of screening tests. So not reactive, but positive. It also allows us to do not only diagnosis for HIV, hepatitis, and tuberculosis, and some STIs. It also allows us to do viral load monitoring for HIV and hepatitis C. So it opens up a lot of possibilities, and it's very, very easy to use. The only complicated part is collecting the samples, and for TB, it's biosafety. Also, currently, we have the possibility of providing testing in a huge number of well, pretty much anywhere, to be honest. So you have outreach possibilities to go specifically to key populations. You have mobile units, and you can set up mobile labs, which can actually provide both diagnosis and disease monitoring in a mobile way, so they can circulate to wherever you want. There's also self-testing and self-sampling for all of these infections, less for TB. And we've been developing, especially now with COVID, also contact tracing and partner notification, which are severely underused. And index case testing, for example, and Maka will speak a bit about that, is a very, very interesting strategy, as well as social network recruitments. So there's a lot of options. We have to be able to adjust these options to the people that we want to reach. The thing is that the different levels of the system have different advantages and disadvantages. So you need a balance that's adjusted to your local epidemic. And the further up you go, the more volume you can do. So there's more throughput. You can do more tests. You can test a lot of people, but the tests are usually also more complex or require more equipment. They require more biosafety and so more security overall, more training, but the test menu is also bigger. As you go down in the complexity cascade, so to say, you have less number, less volume, but the tests are also simpler. They require less biosafety procedures to be implemented. They require less training to learn how to do, but the test menu is also not that big. So there's advantages and disadvantages in the different levels. Very quickly, some key things. So the system is where the guidelines become real or not. And the issue is that in most cases, they're not. So there's a part that's nice in every system, but usually there's a lot of things that can still be improved. Usually the normative and regulatory framework is how you implement the guidelines. So, and there's a lot of things missing in our normatives, norms and regulations. I mean, self-testing and self-sampling, for example, still have a huge gap in terms of regulation in Europe. All the testing systems need to be adjusted to local epidemiology and focus on the key groups. And the key groups are the people who are most affected by the epidemics. And they change from country to country. But in general, in Europe, they're roughly always the same. Participation and involvement of communities is absolutely essential. It makes a massive difference in actually being successful with your testing program. You can have approaches that are based on population, so test everyone or as many people as possible, or on groups, and that also depends on how you set up your system. It's really critical to monitor, not only to see how you're doing, but to improve quality and to be able to adjust your services to the needs of the people who use your service. It's critical to integrate. It maximizes your efficiency and it provides a better service to people, but it also saves you time if it's well done. It saves you resources. Well, it increases them, but overall to the system, it saves. If you manage to integrate properly in big scale, you actually invest less overall to get the same results. So your case finding theoretically is better if you integrate properly. And advocacy is always needed, as well as good data. And we're going to look into that more in detail in future sessions. These are some of the key challenges. I'm not going to go into them now. We're going to speak about them in another session. And we're going to speak about this in another session too. So I'm going to skip these for now. Thank you very much. So I hope that was understandable. I know I tend to speak quickly. As I said, please feel free for questions, comments, etc. Was it understandable?
I think it was very clear, Daniel. Thank you.
Okay, so if it was clear, I'm very happy. At any point, even by email, the email is on the last slide. If you have any questions or if you want more information about anything, please feel free to contact me.
Thank you. So maybe we can move on with Maka's presentation, and then if you guys have questions, we can address them during the discussion.
Now, at first, I want to introduce myself because I'm new for this group, and as I read their names and surnames, I can't find anyone familiar with me. My name is Maka Gogia. I'm from Georgia. I live and work in Georgia and represent Georgian Harm Reduction Network as an organization working with people who inject drugs. But besides the program management, I'm a technical advisor and a trainer for HIV and hepatitis C community organizations in Georgia. And I have 13 years of experience being actively engaged in advocating better accessibility to HIV, viral hepatitis, TB, and STI treatment and prevention for services for key population. I'm a member of European AIDS treatment group for about 5 years, and now currently I'm a board of director, mainly vice chair of board of directors here. Besides, I represent a group member of European HIV Testing Week, focal point of correlation network, and also Global Fund ECA constituency member. I'm also steering committee member of AIDS Action Europe, and so on. Why I'm talking about this nomination, that I'm with my 13 years experience in low threshold programs. I have a big background in civil society organization, but my basic knowledge education is high medical school and then public health school, but I decided to work on this direction without public state structure. So, as my colleagues highlighted today, very important issues regarding HIV testing guidelines and integrated models of care. I wanted to talk in more details of HIV testing, more specific issues that was not told. So, in case of questions during my presentation, please stop me. Give questions and let's discuss what will be interesting for you. I'm sure here among you there are persons who are working in low threshold programs, in prevention programs, and if you have a different kind of experience and different kind of view what should be changed or something, you can also provide your suggestions, because the suggestions from people who are in a practical work are very appreciated, and they see some very interesting things inside the program. So the name of my presentation is the role of civil society organizations in HIV early detection, referral, and linkage to care. We all know quite well that civil society organizations played a huge, crucial role in HIV prevention, early detection, diagnostics, and referral. And so far, they are engaged in actively in prevention and treatment as well. I wanted to highlight the reasons why these organizations are more stronger than state agencies and why they have more advantages to manage HIV screening activities in the field. So here are some of them. This is a meaningful achievement of one study conducted and published in PubMed, and the results have shown us that civil society organizations have rich experience working at the community level. Their autonomous nature allows them to respond more quickly than governmental agencies. They have access to marginalized groups. They are well trusted and well believed by community members. They generally work with the target groups to raise their self-esteem. They can act as a bridge between the community and the national level. They often employ innovative methods, and the next session I will talk about the peer-driven intervention and optimized case findings that support low threshold programs to reach new clients and reach new hidden groups that were unrepresented before in the programs. And as well, the methods that use civil society organizations allows for cost effectiveness. As Daniel mentioned, they can provide different kind of screening services and linkage to care measures, and together this gives the possibility to present the services more cost effective, and the donor, I mean, who it can be, the donor, international donor or government as a donor, can save significant monies on integrated services. There are, I identified several basic fields that are civil society organizations involved. We call it, them in different names: low threshold programs or service delivery areas, HIV prevention points or checkpoints, whatever you want to call them. For example, in Georgia, we don't call them checkpoints; we call it service delivery areas. But maybe you have different opinion on that. But the content of them is the same. So this includes the screening of persons who would otherwise not be tested and who might seek anonymous HIV testing and learn their HIV status. Here is also point of care diagnostic that we call confirmatory diagnostic, that is possible also to be conducted at our services. Another important part is referral, linkage to care, support in long-term adherence, and patient education as a meaningful part to support people starting HIV treatment and to continue it till the end. So I identified, according to the international, national, and local guidance that we have at European level, at UNAIDS world level, at country level, or maybe at the organizational, I mean local level. Now, all the programs, testing programs, are based on three basic screening parts. So this is pre-test counseling, and this is testing, and this is post-test counseling that is different based on HIV status. So civil society organizations, as I mentioned, are very strong to reach the marginalized groups that are different significance for different countries. For example, for my country, drug users and the MSM population is quite a significant one. Then Christos mentioned the basic principles to work with this key population during providing HIV testing service. Someone wants to be added here? Manual? Okay. The basic principles of HIV testing, everyone who works in this sphere agrees that the services should be done on a voluntary basis, based on informed consent and based on anonymity and confidentiality of clients. in programs, we don't use the ID numbers of clients. They are collected different kind of unique codes, other non-identified recordings, and so on. It depends on the structure of the country regulation and the NGO inside the regulations. So the informed consent before HIV testing can be verbal or written. It also depends on country regulation. Sometimes people refuse to make their signature on any kind of paper, and it's acknowledged by all international regulations that verbal consent is a real form of consent, and this can be approved before HIV testing. And the client before testing should receive information what the HIV test is provided, and it's also meaningful that the service providers ensure the services that are responsive to clients and community needs and priorities. As well, it's important to be appropriate to clients' culture, language, sex, sexual orientation, age, and developmental level as well. And ongoing training of staff and personnel of harm reduction of loss threshold programs is very huge, very meaningful, because if the client has that staff is not familiar with the issues and could not answer the questions properly, he starts to not believe the things and services they are provided. It's also very, very important one. The elements of HIV prevention counseling that is happening during HIV testing are also very important. Client should receive the information he really needs and he really understands, and this should be done in a language that is easily understandable for them. So the counseling that is happening during HIV testing or after the testing should determine individual risk through risk counseling. When we are talking about the risks, we are talking mostly about unprotected sex and injection drug use practice that is more common in Eastern European and Central Asian countries. And the HIV counseling itself includes two important parts: this HIV information provision and HIV prevention counseling. So HIV prevention, which measures are envisaged in the world, in the country, it's this office, in different offices, so the persons could be referred to. And counseling itself can be provided in different manners. So basically, we had before COVID era face-to-face counseling. This was normal. Now that's two persons counselors, and the client were talking and discussing the risks and giving the proper direction where to refer this the client based on their risk. But after the COVID era, we have different approaches. That also was familiar to NGOs even before, but now it became more actual. This is telephone counseling, online counseling, group counseling. When I'm talking about group counseling, I am meaning pre-test counseling and delivering the information that is not private for one person. It's also important to ensure high quality HIV prevention counseling. Most countries have their written protocol, country guidelines that is written every step that is done by service provider, what to say, how to say, what to emphasize, and so on. And a different approach is provided in HIV testing, new module that we call self-testing, and we will talk about in the third session. Quite interesting future self-testing is providing us, and it's a very new model, maybe at maximum 5 years old approach, not understandable all the consequences, but this is a future really for the unreached population, and the counseling for this type of testing differs from the ordinary counseling methods that we are using for more than 20 or 25 years. What about key points on HIV testing? What should know the clients of checkpoints and the low threshold programs that civil society organizations are using, the tests that are pre-qualified by WHO. These tests enable testing in different fluids. So this is whole blood, serum, plasma, oral fluid, urine, and so on. This information should be provided before the testing, and it will be best if the service provider has a different option to provide different kind of tests. But unfortunately, NGOs not always have such expensive opportunities, and they provide only blood screening, especially the organizations that are working in eastern part of the world, of the Europe. Sorry. This is also acknowledged that clients prefer less invasive and more acceptable venipuncture at different outreach settings. A provision of HIV test results during single visit at the time of testing. Hopefully most organizations have the possibility to provide the test results in the same day. It's the best practice, but if this does not happen, the client also can receive post-test counseling depending on the mode of delivery notification of testing results. And it also should be acknowledged client preferences and acceptability of HIV testing, and during the consent giving, this also should be negotiated with clients. What type of test kits will be used during HIV testing? And about HIV testing results, the testing results should be as accurate as possible. The test should be, as I mentioned, of best quality and subject to quality assurance mechanisms. And in the country, there should be a system that supports NGOs to ensure high quality test provision, and the national reference laboratory should support the NGOs with high quality tests before procuring large amounts of test kits, before starting the new test kits in NGOs. Then reference laboratories should support with ensuring the quality. This is a recommendation, but I'm not sure that they are acknowledged every time. And also it's very important to use explicit language when providing test results. The client should understand what is positive, what is negative, what is unclear results of testing. And also there are different types of modes informing clients about testing results. This is a face-to-face notification, telephone notification, online notification, notification by post, and it's very mandatory and meaningful that no third person should be involved in notification, and to secure anonymity and confidentiality of the client. Also, Christos mentioned that every country guidelines and international guidelines also include inside testing algorithms. What happens if HIV testing result is negative, and what happens if HIV testing result is positive, and what about unclear testing results. So the NGO working in HIV testing service provision should know exactly when and how to address a person with positive or negative results. And here I underline the basic structure of screened positive and screened negative individuals after HIV screening. So if the person is positive, the connection should be ensured to receive proper treatment services, I mean HIV, hepatitis, TB services. So the patient should be referred to this clinic, and NGO should have preliminary the contacts with these clinics, and they should have contact names of doctors or nurses to whom the clients are directed to. And what happens in case of screened negative individuals? They are connected to comprehensive prevention services, depending on the client nature, depending on the risks they perceive. They can be directed to a needle and syringe program, opioid substitution therapy, drug checking program, and this is for people who use drugs. Other clients, other marginalized groups can be referred to condom and risk reduction programs. Here I mean MSM, sex worker, trans people, and youth also. Here's also very important program PrEP worldwide, they're very famous, and the clients should receive information about the existence of the program and support them to refer to these clinics. There's MSM, trans population, sex worker, or serodiscordant couples, where one of the couple members has no viral suppression. And also the counselor should inform about PEP service. This is PEP post-exposure therapy. The person that perceives the risk after risky behavior. And case management, I would not avoid this meaningful part of service provision of NGOs that is not referral, that is an action that supports client to receive medical, psychological, or legal service that he or she needs. He makes social adherence to the clinic to receive these services, because not all clients are able to go to clinic to talk about the disease openly, the risk behavior, and maybe he will delay going for treatment initiation. So the person from NGO supports receiving different kind of services. Case manager also increases supports to increase patients' capacity to manage problems. And I want to highlight the model of CARE's optimized case finding. And then the programs, for example, in Georgia, we have this model. We are inviting sex or needle partners of HIV positive individuals to come to our service to be screened on different diseases and to receive free medical consultations, and in case of screened positive cases, they include them in treatment programs of HIV and viral hepatitis. And reporting and feedback, that's an important part also in the work of non-governmental organizations. Is not only they report, and they should report to donors that are financing them, but they have obligation also towards community to report them about the work done during the year or months or some quarter and so on. And they should collect also the needs from community and preferences about the services they prefer and need currently. And this is the last slide. I can't avoid the COVID's impact on HIV testing in most countries. In the last slide, you can find the link how UNAIDS published a number of countries that are saying how their testing services were interrupted during the COVID pandemic. And there is a significant decrease in number of HIV testing during this month, starting from February to 2020. And we so far don't know about the negative impact of COVID on HIV services, and it will be more visible in the next years. I mean here, the late diagnosis of HIV, late initiation of HIV treatment, and so on. These are resources that I mostly use to prepare the presentation, and this is a big thank to you for your attention. Thank you. I'm ready to answer your questions in case you have them.
Thanks a lot, Maka. Does anyone have any question regarding the presentation from Maka, or should we go directly into the general discussion? Because if you guys don't have questions for us, we do have questions for you. So maybe we can directly move on with that. I'm going to share my screen. We prepared a few questions for you to explain to us what is the situation in your respective countries.
If you don't mind, can you briefly tell me, as I'm new, if you are talking in HIV service provision area, it will be more interesting to discuss the issues with you, because exchanging the practices will be very useful. Oh, thank you, Marin's question are very useful.
So basically, the idea is that we wanted to have a more general discussion with you, the trainees, and the three speakers. And we would like to know for each of your countries or each of your local situation, how is testing working in your country? Do you know if the guidelines that were presented by Christos are being implemented in your own country? Is there something missing? Do people have actual access to testing? Is the testing system working well where you are? Who are the people who are more at risk, and do they have access to testing? And what do you think would be the kind of advocacy needed from activists in your country around testing? So I let you just unmute yourself and talk, please.
That's a lot of questions.
Yeah, you don't have to answer everything.
Yeah, I'll try. I'll try. So I will speak for Poland. We have several testing points across the country. The biggest number of them is in Warsaw. However, in the big cities, I think we have something at least one, but maximum two. So definitely the problem for the testing is that people who are living in the smaller towns or in the countryside or whatever have a difficulty accessing the testing point. I know that there are some new programs on home self-sampling and home tests, but I cannot say how popular that is at the moment and if this is successful or not. For the guidelines, honestly, I don't know. I would have to double check how is it implemented. Definitely what is missing in Poland is the linkage between the testing point and the treatment point. So I know something has changed very recently, but as I was tested 3 years ago, and when I received the positive test result, I was just kind of left with the result, and then I had to contact the outpatient clinic on my own and make the appointment and so on. And that was a little bit that was kind of difficult. It was a bit challenging for me, and I know that there are many people left on the way from the testing point to the outpatient clinic, that they never appear for the treatment, or they appear very late for the treatment. And I think this is something that should be improved. I know there is some improvement recently. So now some of the testing points, in case of the positive result, they are calling to the outpatient clinic and they are setting up the appointment for the person who got the result. And that's already an improvement. In terms of the people at risk and if they have the access, I think basically the trouble is the geography. So as I said, whoever lives in a big city those points are accessible. They are now accessible even due to COVID. They stopped for some time, but now they are back to work. So they can be accessed. However, in the smaller or in the eastern part of the country, basically there are, I think, a very limited number of places where a person can be tested. Yeah, so that's from my side, I would say.
I don't know how this is supposed to be structured. So sorry if I'm cutting the foreseen organization, but to follow up on that, and actually that was kind of what at least I was looking for to get from you guys. So you mentioned a lot of very relevant things. I think that there's one thing you didn't mention. I presume that everyone knows, but I think it's also very important, which is the general political environment in Poland at the moment. Mm-hmm. And so the overall social messages, etc., that are being transmitted by the government are, exactly the opposite of what they should be. Let's put it that way. Mm-hmm. And this creates a very poor environment. And I mean, I followed a bit of Poland's progress in testing over the last couple of years through Integrate, the joint action. And there has been more collaboration. There was always kind of some lack of interest at the higher levels of the government, but at a technical level, there has been more collaboration, and there was an ongoing effort to improve things. But actually, you raise a lot of very relevant points, which is this is mostly in the big cities. There's still a lot to go to provide options to people who are out of the big cities. And I think that self-sampling and self-testing could be interesting there. But then when you have to go to a clinic on your own, and when the people in the clinic, if in case that you're not a normative person, and even, I mean, generally towards HIV and sexually transmitted infections, if the overall way that you're treated is not exactly the most pleasant, you will lose a lot of people. So I think the general social environment really needs, I don't know exactly what it needs, but it needs some changing at least.
There is also another aspect, and I think you guys mentioned a lot about the prophylaxis, and in general, in Poland, when you are already a patient, you get a full treatment, you get good drugs. That's not an issue. Of course, if you are admitted to the, if you get admitted to the outpatient clinic, but in terms of the prophylaxis, the country doesn't do much, or I would say it's almost nothing done. So very recently, we had a campaign launched by the Polish AIDS Center, which is like an institution that is controlling all the HIV treatment in the country. It's a governmental organization, so we have a campaign which is an outdoor campaign, and what is completely not being mentioned in the campaign is PrEP. There is not a single word about PrEP. There is not a single word about U equals U. However, they are still promoting the sexual abstinence and being devoted to one partner for the whole life. That's a very, that's very 80s, or that's the very 90s, I would say. So in terms of the prophylaxis, we are at the end of the line, I would say. It's a nightmare. Yeah.
Greg, I want to ask to you, because all the news we are receiving from Poland, unluckily, because the government is worst, because the ultra-right and like that. What's your opinion? Because all the NGO, we need the support for the ground from the government.
Yes.
What's happened in your country, the relationship between the NGOs and this government?
Very good question. So there is less money, definitely. The access to the money is limited, from what I know, from what I understand. I am not directly involved in getting the funds, but I know that this is not that easy as in the previous years. There are some other options. So you can get money from the government, from the Ministry of Health, or from the HIV, from the AIDS Center. But also there are some programs where you can apply the money to the to the city, like to the city of Warsaw, for instance, or to the other city, big city. And then the chance for getting this money is a little bit higher, because usually the political option running the biggest city is completely opposite to government. So this is the kind of a rescue. But in terms of money from the government, you're right, it's limited, and it's less and less money. Yeah, absolutely.
Luckily. Thank you.
Well, I can go next if you don't mind. So here in Spain, testing is quite okay, but right now, because of the COVID situation, there are been a lot of delays on the appointments with the doctors and everything. But on my opinion, the guidelines are only implemented by organizations, not by the public health system. Because sometimes when people go to the doctor to ask for a blood test or STIs screening, they say they don't want to do it, or maybe like they said to me once, like, if you don't have any symptoms, I won't test you, which is something crazy. So yeah, it's been implemented, the guidelines, by the organization, but not on the public health system. But then once you are in the system already, once you have been tested already, the access to medication and follow-up and everything is been quite okay. And also, one problem that we are finding is that public health system and doctors sometimes don't want to make a deal with organizations, to call it somehow, because usually when we do a reactive test, the people have to go to their doctors, and their doctors have to send them to the main clinic for HIV. So it's a process that it will take a few weeks till the person can get all the tests and medication. But in other places, other cities, with different hospitals, there are professionals who wants to work directly with us, and so we make deals, like we can send the patient directly to the clinic. But again, it's something that is not really implemented. It's implemented with some doctors and not the other ones. So maybe this is something that must to be changed in order to make the process more easy for the people to get access to treatment. And as well as like in Poland with the big cities and the small cities, there are more facilities to get tested in the big cities, but not in the small ones on the countryside. So that's something that needs to be changed as well.
Maybe we can get Manuel as well, since it's two Spanish experiences.
I want to talk about PrEP situation now because of the COVID. And I want to tell you, 1 week ago, I was offering the rapid test for a gay boy. This is a Spanish boy, and he is living in London till 2 months ago. He is taking PrEP in London. And he said to me, he talked to me about this, about the PrEP in London. I am taking PrEP in London, and I need to pay £30 in the public health service to receive the PrEP. But now, because the COVID pandemic in London, he said, when I go the last time to take the PrEP, the nurse or the doctor, he said, they said, you don't pay now the £30 because the pandemic, the government have decided to stop the pay because they thought now because the pandemic, the situation is worse, it's more unemployed people. It is the situation in United Kingdom about PrEP during the pandemic, but here in Spain, I think on the rest of the country or all of the country is just the opposite. During the pandemic, here in Spain, is a stop in the public health service. They stop the service, and it is very different situation if you are living in Spain and you are taking PrEP. If you are living in London, it's well, I'm only talking about PrEP, but we need to talk about the quickly test. The girl for Georgia, they said probably during the pandemic we are offering less tests. Less people are testing. You are talking about all the syphilis, you are talking about C and B hepatitis, but I'm thinking about gonorrhea also. It's very important to offer. It's more difficult from the NGOs offer this test. But we need it. We need it also to offer the test for chlamydia and gonorrhea more than hepatitis, I thought. Because probably you can find in the MCM people more positive resolved about chlamydia or gonorrhea, more gonorrhea than chlamydia. When you are talking about this different rapid test, I think we need to improve the test for the other STIs, but it's more expensive, it's more difficult to offer. Because we need the doctors, we need the PCR machine, it's a lot.
Yes. Just to ask you, don't you have the healthy clinics that you're referring such persons for complete STI diagnostics? In Georgian case, we have, because our NGOs don't have enough capacity, I mean, technical capacities that need those disease diagnostics.
Maka, I want to ask you, what is the situation of FTIB in Georgia? Is the moth infection is the same like in the Western Europe?
Gonorrhea?
No, HIV. I'm talking about HIV. What?
Is
The
it-
MOTS group is also MCM people. What happened in Georgia about HIV?
Georgia is a low prevalence country, and we have yearly 800 cases per year during the last 5 years. The most common way of HIV transmission is related to drug use, but the prevalence of HIV is highest among MSM population. It's 21%. Can you imagine the rate? 21% among MSM, and they are quite hidden population. So this self-testing strategy that we started several months ago already supported us to find 21 new cases in 6 months out of 105,000 tests. So this is the real situation, and regarding treatment, everything is free of charge, and these prevention services are accessible in big services for MSM population, but in small cities for drug user population as well. So we can say that harm reduction supported the HIV epidemic too much, and it's not more than 2% in drug user population, but it's 21% in MSM population, and heterosexual contact became dominant. It is 55% among the total number of HIV registered cases. But also we have failure with the HIV testing during this COVID pandemic. Really, and the treatment initiation and everything is related to the pandemic, because the clinics that are treating people with HIV also are receiving and treating people with COVID also, and people try not to go to clinics for treatment monitoring and so on purposes, and they are receiving only teleclinics and online counseling. I suppose there will be the same situation in your countries as well.
Thank you.
Can I add something? Since anybody's, unless somebody wants to answer the questions, I know there are people who haven't spoken, like Sotiris. Hi, Sotiri. I think you're the only, and Attila. The one thing I would like to add is, Maka mentioned the 5 Cs from WHO when it comes to testing. The consent, confidentiality, counseling, correct results, and linkage to care. And I was thinking that in some countries, we think that we implement the 5 Cs, or at least we say we implement the 5 Cs, but I'm not saying that we are really lying, but we don't realize that we don't quite implement them. Like, for example, if you go to some private laboratories or public hospitals in Cyprus, and if you ask the nurses or the doctors if they are doing counseling before the testing or after a reactive testing, they will probably tell you yes. But what kind of counseling? How is the announcement being made in these settings, for example? Especially if you are in that marginalized group, that you are a trans woman, or if you are someone who is involved in chemsex, or I don't know, marginalized groups, or a migrant or an asylum seeker. What do we mean by counseling? And what do we mean by the first one, consent? I know situations where people are just signing a paper that they are going to have an operation, for example, and they find out that there was a test done on them, for example, and they gave a signature without really understanding what they consented to. Or sometimes it's just a given. I've heard about situations where people who work in private labs, just for the lab to keep the ISO, is basically forcing the people working in the laboratory to take a test. And I'm thinking that the 5 Cs are nice when it comes to the theoretical background and, you know, the guidelines and WHO, but the people who are expected to implement them, and I'm just taking the 5 Cs as an example, there are so many other guidelines and suggestions that are really not the case there. It looks like it's not implemented not only to the fullest, but not even in a way that can support everyone. So I'm thinking that one hole that the whole system is leaking from is the actual implementation and what we mean by the implementation, and the other part is how that 10% who is left behind. What does it mean to have a 10% that's left behind in testing? It means that we are not looking for them. We're not looking for that 10%. And probably that's the 10% we can't find unless we make an effort. So yes, we are not reaching the 90, but it looks like the strategy of numbers and targeting and focusing and, you know, someone sitting and preparing this kind of nice theory of an approach, it's not really working, even in European countries that don't have the issues of I don't know, Hungary, for example, or Poland. Like, I'm thinking of Cyprus, which is a very small country. It's like a village. And in reality, the size that could be the reason why everything could be happening correctly, let's say, or closer to what we would want, it's the reason why it's not happening. So I'm wondering, you know, you guys coming from different communities and different cities and different populations in terms of how big your cities are or your countries are, if you're also facing, you know, similar situations. Because I'm thinking that, you know, in countries of the Eastern Europe, for example, it's very visible that these guidelines are not being implemented. In other European countries that we say that we implement them, do we really?
Can I talk on that, please?
Yes, Sotiri. Yeah.
I could talk about Greece for hours. I could do a whole presentation about how the things work in Greece. But I would like to start with a personal story, actually 2 stories. One is personal, one is not, that says a lot, and then I will answer the questions. So I remember some years ago.
Sorry, so you do remember that the session is recorded, right?
Yeah.
Let's say.
I remember some years ago that I was 21 and I had my tonsils swollen, so I went to the ER to have them checked. And when the doctor was going through the questions and finally asked me my sexual orientation, and I said I'm gay, I remember the chief doctor took me to an office and she started asking me private questions. And even though I said that I did have protected sex and I didn't have unprotected sex, she told me that we have to do HIV test because I'm MSM, so it doesn't matter. So I did the test and the results were supposed to come in 2 weeks. I called in 2 weeks. They told me 1 more week. 3 weeks went. I went back to my hometown, which is a small village, so there's no testing. And when I called after 3 weeks, the doctor was on holiday, and the nurse or something like that told me that they can't do, actually, they don't have any results because they can't do testing for outpatients, but only for patients that are in the hospital. So I was 21. I was not out in my family back then, and I had to travel to a bigger city to go to an NGO and do a test and take my results. And this says a lot about how the testing is in Greece. And also another story is, I'm not sure if you know, but some years ago, the Ministry of Health published the photos and the information of some sex workers who were tested and they were HIV positive in the mass media. None of them is in jail right now. I mean, from the government who published all this information. And of course, these sex workers went to jail because they were HIV positive. And going to the questions now, there is one NGO in Greece. They have one chapter in Athens and one in Thessaloniki, which are the bigger cities. And they only do testing on HIV and syphilis, but as far as I remember, nothing else. And if you want to do testing, you have to book an appointment at the doctor at the hospital, prescribe you the exams, and then book an appointment to do the test and then wait to take your results. Unfortunately, I think that the whole campaign is more concentrated on men who have sex with men. I don't really see anything around trans people or around sex workers. Unfortunately, I'm not sure why this is happening. And also, I think, also commenting what Christos said, I'm afraid that the majority of the workers, healthcare workers, if it's not an NGO, so in public hospitals that are working on HIV clinics and testings, are completely uneducated. On HIV, there is lots of stigma, there's lots of racism, there's lots of homophobia, lots of transphobia. Like, I really think that there's a lot of work that should be done there, like on public services, on public hospitals, to the workers that are working there. I know from friends that they're going to take their medication, and in Greece, and the secretary makes jokes about them being gay or about them being HIV positive, and that person is responsible for distributing the antiretroviral drugs to HIV patients. So yeah, I think unfortunately, even though there is some work done from NGOs in Greece, I think we are far, far, far behind from being even okay. Like, there's lots of racism still on the public services, unfortunately.
It's interesting to me because I keep hearing similar experiences from a lot of different countries, and you would expect, I mean, it's sad that that happened to you in a testing service a few years ago. It's even sadder that it continues to happen to a lot of people today, because, I mean, I don't know how many years ago it was, but over the last few years, mostly over the last 5-6 years, there has been more eyes on community testing, so on testing in general. So things have improved a bit faster. Before that, it was absolute chaos everywhere. And so, I mean, the problem is that type of situation continues to happen in pretty much every country, in more or less services, but pretty much in every country. And I think that not only you, but you touched very clearly on one essential problem, which is the structural part of it, which is socially people are based in prejudice still, and this affects doctors and healthcare workers. And if socially, for the big public, it's very hard to do something, in theory, for people who work in health, it should not be difficult to have at least some basic rules that people would have to follow to guarantee at least respect for everyone. Because we in Portugal, so I've been connected to an organization in Portugal that has testing centers focused on different key populations. MSM, people who inject drugs, sex workers, trans people, migrant communities, etc. So we go with a lot of people to health appointments. And a lot of people tell us that if it wasn't for someone from GATT being with them, they would not have underwent the entire process. Many of them because they don't even know where to go or what to ask, and many of them because the way that you are treated by, sometimes it's doctors or nurses, other times it's other staff, people at the reception, security, a guy that lives on the streets or a woman that lives on the streets that's poorly dressed did manage to have a bath, that goes into a hospital, is not well treated. And this type of overall environment is absolutely essential to get people to actually want to go get tested, to want to go get a doctor's appointment, to get their treatment, etc. And that's something that I think in general throughout the world, but in Europe, which is where we are, is still very much lacking.
I think we had this discussion the other time. I think that this is the reason why it's so important to have sexual health specialized centers, because my experience from the UK, where I was living for 2 years, I am a PrEP user. I was in the UK as well. And I was going to the clinic. They had my number. They were calling me. They were calling me for tests. They were calling me for results. They were calling me for, giving me my medication. And everyone who was working there had a goal. Like, they knew what they were doing. They were working at the sexual health center. So they were educated and they knew their job. And I don't know, I just like, I don't say that, I think it's very important to have LGBT staff in these clinics. I don't say that, straight people shouldn't work there, but it's very, very important to have like LGBT staff, because that sexual health clinic I was going in Bristol in UK, most of the staff was queer. So of course it was much more comfortable for me to go there, because they knew exactly what I was talking about and they were educated. But also then there is a problem, because, for example, when I was discussing with one of my friends who is from Jamaica, there is, like, for example, people of color, it's also weird for them to go to sexual health clinics, and there's a big problem in their communities around HIV, because they don't really have access and there's no campaign for them, and it's hard for them to trust these clinics, because, of course, besides the homophobia, there is racism against them.
If I may add to what Sotiris is saying, the acknowledgement of the privileges we have and the privileges we don't. I mean, even in the UK, I'm not sure if someone can actually access NHS, which is the national health, if they are undocumented, for example. I'm not sure if someone can access health services that easily if they live in a village somewhere outside the city and they are trans, for example, whether this is visible in their gender expression or not. So I think it's quite, we are going to address all these things, I think, inevitably in the community-based setting, but something that comes out from the whole discussion today, I feel, is how important is the community-led services. And right now, maybe in some places of the world, maybe it's those services, the community-led services, that are actually implementing most of these guidelines, which is a bit ironic.
I wanted to add one comment regarding the case story from Greece. I sometimes think that we have the same stories here. Sometimes I think that Orthodox countries are more radicalist toward homophobia, to even drug use, but for MSM especially. We even had one project, USAID funded project, that intended to include priests from Orthodox churches to get information why we are doing HIV testing. And we had such contradictions with each other, and it was 6 months project. At the end of the project, we received such a big result that the information, HIV counseling and information about HIV prevention services were included in Theological Academy, that is also the biggest educational center for Orthodox Church priests. So I think that the future of increasing tolerance to these marginalized groups is to work with these people. They have quite a big authority in Orthodox countries, and their power is quite great, and they empower people or general population against these groups, and there should be initiated dialogue with directly them. It's my personal exception.
If I may, that's a very good point. I would just change one word in that, which is, I wouldn't say orthodox. I would say in all countries that have a strong religious presence in society, because Poland is the same. A lot of Latin countries, it's the same to a different. I mean, the social organization is different in Latin countries and in Central and Eastern Europe. So the social organization is different, but the limitations that come from big religious background in the country are very clear on the way that you speak about sex, about different sexual identities, about different identities in general, actually. So everything that is different from the norm is tends to be very repressed. And so I think like a progressive vision from religious leaders is really, really important to increase, as you say, acceptance and tolerance. I remember seeing a presentation in an LGBT conference about the impact of people who were religious when they were coming out, when they were trying to come out to the people who were close to them in religious families, and it had a huge weight on their mental health and their well-being, because theoretically their religion told them that that was wrong. And so again, I mean, even for people themselves, but for society in general as well, I think it's a very good point to touch. I just like to go back quickly to what Christos was saying earlier about implementation of guidelines and communities being who implement them the most. I've been involved in developing guidelines for a couple of years, and I think that so the attempt with a guideline is that you put a stamp on something that you say this is perfect, this would be ideal. If things would be done like this, it would be wonderful. This is how you should do it. But this is not a law. It's not mandatory. And to do what's in the guidelines takes a lot of resources, a lot of money, a lot of planning, a lot of will. And different countries have different quality in terms of staff, different money, different social priorities, different political priorities. And so the guidelines are there as a reference. And it's funny because, well, it's funny because community has always been in the center of the guidelines from several angles. First, because we demand guidelines. We demand the big organizations to tell us how should things be done. And then we demand to be a part of them, to participate in their development. And then we're part of implementation, or should be. And it's funny because ultimately we ask for something that then we are the ones who will apply, but we also ask for something that, so the guidelines give us the responsibility of trying to advocate for them to be true. They're not true 100% in any country, but they're also not fake 100% in any country. So there are countries that have implemented better systems and worse systems. And I think that the idea of looking at the guidelines is thinking, okay, what are we missing? And where are we going? What are we going towards? So what's the goal? And the goal is providing good quality testing options for everyone, providing good treatment for everyone, providing good follow-up for everyone, etc. And it's very hard. It takes a long time. And that's why guidelines keep changing, because even with time passing, we understand that situations are different. We get more evidence, etc. So it's not a static thing, and they have to be adjusted to context. I mean, guidelines, as Christos was saying, they're very nice in paper, but sometimes it's not possible. And so we have to do, in a certain sense, the best we can.
Well said.
Well said.
I think it's, if I may, I think it's a nice way to conclude the session. Maybe I think what you just said, Daniel, was a very nice conclusion. So if no one else wants to add anything, maybe we can close it here, and we can talk again on Tuesday evenings, because we're going to talk about community-based testing.
We're going to actually talk about how we do it properly.
Yeah, exactly. How do we implement it? So thank you everyone for joining. It was a really, really great session, and thank you for participating. I wish you a very nice weekend, and we see each other next week.
Thank you for today. It was very nice. Thanks.
Thank you for all.
Likewise.
Thank you all.
Thanks
It was a
all.
pleasure.
Thank you.
Have a nice weekend.
Bye-bye.
Bye-bye.
Bye.